Hereby, I open this academic ceremony in which Plaxcedes Chiwire will defend her academic thesis titled Investigating Patient Preferences in Public Health Service Delivery in the Western Cape Province, South Africa. May I invite you to do your presentation, which is also recorded online, so many people in South Africa, I assume, can follow this academic session. The floor is yours.
Good morning, everyone. Thank you, Prorector. Thank you to the members of the Defense Committee. Thank you, friends and family, and those who are watching online. I will be presenting in the next 15 minutes the research from my PhD study entitled Investigating Patient Preferences in Public Health Service Delivery in the Western Cape, South Africa. South Africa has a population of about 60 million, and Western Cape has a population of about 6.5 million, so which is 11.5% in South Africa. The healthcare strategy for the Western Cape is moving towards health delivery, which is towards patient-centered approach. And the Western Cape struggles with a quadruple burden of disease, which is communicable diseases, trauma and injuries, HIV/AIDS, and non-communicable diseases. There is a lot of inequity within the South African context and within the Western Cape context, which is coupled by budget deficits, limited facility and hospital budgets, poor health outcomes as a result, and also high unemployment. And moving towards the idea of universal health coverage and an equitable health system, in order to improve health outcomes, it's important to understand patient preferences. The objectives of the PhD were as follows: to gain insight into factors affecting the choice of public health facilities, which is at the primary healthcare level, to ascertain what factors affect the choice of people deciding which facility they want to go to, and that was at Bottesick and Goodwood clinics, using hypothetical situations called the discrete choice experiment, to ascertain whether people are actually willing to pay for access to healthcare services, despite the fact that the primary healthcare services are actually free at the entry of service, and to gain insight into public HIV testing preferences. These are the two particular clinics that we sampled. It's a no-fee service, offers a comprehensive public healthcare coverage, a package, and the headcount at Bottesick is about 15,221 patients, and Goodwood about 30,918 patients. Bottesick is a more affluent area, and we sampled adults that were 18 years and above. And the participants were approached as they waited for consultation at the reception, pharmacy, and the doctor's waiting rooms. The study approach. We took two study approaches. One of them was to actually ask the questions in a group setting, which is called focus group discussions. The other approach was to offer a choice between two hypothetical situations in terms of what facility they would want to use, and also to ask for how much they're willing to pay. The discussions over results, 6 important attributes or factors when choosing a facility were actually the final set. Treatment by the doctor or a family physician rated the highest, followed by a distance to the community day center, availability of medication at the same rating, and confidentiality during treatment, and waiting time, and treatment by nurse. This is just an example of the facility choice picture that one would be offered within the questionnaire, and they had to choose between alternative A and alternative B. Alternative A being a certain facility which offers different factors, and alternative B, another different set of factors. For the first study, we had about 463 participants, 232 from Bottesick, and 231 from Goodwood, and 61% of them were female. The facility choice over results, after we conducted the hypothetical choice preferences, it became apparent that the availability of medication rated higher than all the other attributes, followed by the appointment waiting time, of which At the facility, you can either get there and you are seen on the same day, or you are de-referred and given an appointment date. So appointment waiting time, 20%, treatment by a doctor versus a nurse, 8%, and the distance, 7%, and confidentiality rated a bit less. Medication availability, all of them, they preferred to have all the medication available, and shorter waiting times for appointment and first visits. Confidentiality, they preferred that no one could hear what was happening and the consultation, and the treatment preferred doctors to nurses. They preferred shorter distances. In terms of subgroup analysis, we looked at the gender and the facility subgroups. The females preferred way more shorter waiting times and also preferred absolute confidentiality as compared to the males. In terms of the facilities, medication availability was more important at Goodwood than at Bottesik, and the treatment by doctors was more important at Bottesik than at Goodwood. Goodwood as well, absolute confidentiality required, and shorter waiting times were basically kind of the same level at both facilities. In terms of the question, are you willing to pay if services were improved? We looked at the range of 0 to 300 Rand, which is 300 Rand at that time was $21 US, and that was the amount that was charged by the general practitioners. In that sense, we felt it was better to use that as a benchmark to understand how much value that the patient actually puts on the services provided. They were given task in where to tick, whether they would pay an amount or they would not pay that amount. Participants, 60% were female, 449 participants. The average willingness to pay was $3.60 for a particular visit, and the median was $1.80, and 60% were willing to pay. Determinants of willing to pay, what we found out from the study was unemployment, public transport, and facility attendant actually affected the reason for someone willing to pay, and most of the participants of the study let us know that unaffordability, providing health care was actually a government's responsibility, so why would I want to pay? And poor service provision was a reason for not wanting to pay. In terms of the HIV study, this was a sub-study in looking at how clients who come in for HIV testing actually choose the facility that they're going to go and test. And the reasoning behind it is there is a high prevalence, very high prevalence in South Africa and the Western Cape province. About 13.7% of South African population as of July 2021 were infected by HIV, and the number could be higher now. So it is important that we understand the preferences for the people who are testing for HIV in order for decision makers to make a better informed decision and for priority setting. So in terms of the study itself, it was adopted in such a way that we took a study that was done in Tanzania and another one that was done in Colombia, and this helped in also comparing. But at the same time, we looked at the context and if it fits South Africa, and of which it did. They were presented with also alternatives of which factors they would look at, and they would choose an alternative A or alternative B. In terms of the factors that affected the HIV testing preferences, methods of obtaining the sample, distance from either you take the test at home or you would have to walk or drive to a testing center. Confidentiality, no one would know that you have been tested, a partner or many would know that you have been tested. Testing days included the weekend and the weekdays. And were the services, in terms of getting your medication, if you test positive, would you get the medication at the testing center or you'd get the medication elsewhere at a treatment center? We had 199 participants, of which 83% of them were female. And a lot of them, 61%, was actually within the youth group of age 18 to 34. In terms of the importance of our results, confidentiality rated quite high, followed by the method of obtaining the sample and the distance traveled at 10%, and slowly was the collection of medication and testing days. So if we looked at the levels in themselves, informing a partner was actually preferred more than not anyone knowing. There was an aversion to many people knowing, so basically most of the people would not want anyone knowing. They preferred a fingerprint on their hand versus actually having the test done on your arm with a prick on your arm, which is venipuncture. And collection at a testing center site was preferred as compared to actually going to a treatment center, a separate treatment center. There was variation between the respondents when it came to confidentiality and distance. In terms of the subgroups, youth group, confidentiality rated high, distance at 18%, and method of collecting sample at 18%. The younger group did not have a problem with partners knowing, and the older group, many people knowing that they had tested, they would prefer compared to the youth group. In terms of the ratings as well of the factors, confidentiality was highly rated amongst the older group. The key messages from the research and looking at all the testing preferences on HIV side and the facility preferences, tailoring services to patients will need to go a long way in retaining clients and actually adhering to treatment. We found that availability of medication is one of the most important factors when someone is choosing a facility, because this directly affects their health outcomes. Therefore, it's important to educate patients as well when it comes to treatment associated to nurses and to doctors to avoid bias on who they want to be treated by. Reinforcement of confidentiality within the testing centers, as this came out as one of the biggest issues. Despite a lot being put in by the government, it seems as though it's still a big talking point. The variations in the target populations need to be seriously considered if you are going to do a target policies that are targeting specific groups. And improvement in services is quite highly valued to the extent that no paying patients are actually willing to pay if better services are offered. We would like to acknowledge the Western Cape Government of Health, the patients who completed the different surveys. I think there are about 750 patients all in all, and the university and the Maastricht University and the Capri Institute. Thank you so much for giving me this time.
Thank you very much. Then we will now open the opposition, and the first opponent is Professor Milena Pavlova. She has a share in health economics and equity, and the floor is yours.
Dear candidate, my congratulations for finalizing your PhD study and for preparing this very valuable dissertation. I was impressed to see that all core chapters of your dissertations are already published in respected academic journals, and this is an excellent achievement for a PhD researcher, and it also indicates the quality of your work. I read the dissertation with great interest, but especially chapter 4 captured my attention. In this chapter, you present the results of a willingness to pay study. Could you please explain what is the meaning of the willingness to pay concept according to you, from a theoretical point of view, and also with respect to the context of your study? What does it tell us? Does it tell us how much people are willing to pay, or what exactly is it telling us, this concept?
Highly esteemed component, thank you for the question. The willingness to pay, in my understanding in terms of theoretical and from the study point of view, is we're looking at how much people are actually willing to part with their money for healthcare services. And basically, are you willing to pay? And if you look at the theory itself, it also looks at ability to pay. If one is able to pay, if one is willing to pay for the services provided, do they have the amount to pay when they are faced with a situation where they actually have to pay for those services? And in terms of our study, what we basically looked at, because this was a free service, the question was basically due to the fact that South Africa is going through the National Health Insurance thing right now. They want to implement that. So the patients do not pay, but at the same time, how much value do they place on the services that they are provided? And one of those ways was to actually look at the monetary value they place on those services. So that was the component that we wanted to study. Are they willing to part with a certain amount of money, and what amount of money would they part with? And would that valuation actually give the policymakers a sense of how much value they're giving to the healthcare services provided? Thank you, Ali. Component.
Okay, thank you. But you, in your survey, you are just asking about the willingness to pay and not about ability to pay. So the amounts that they are given are willingness to pay amounts. We do not know whether this reflects their ability to pay. And second, you just mentioned that your question that you are asking people who are not used to pay for services. So I would wonder whether they would actually pay in reality this kind of services, this kind of amounts. And isn't it just that you're asking about the value they attach rather than the actual price they will pay? So this is something that we can discuss about. Furthermore, I read in the chapter that 60% of the participants are willing to pay about 3.5 US dollar. So it depends whether we take the mean value or the median. So inability to pay was the major issue for not being willing to pay. And you also find that factors like unemployment in distance from the facilities influence whether people are willing or not to pay. May we conclude, so because you say that the willingness to pay concept says something about what the price should be. So if I translate that to the survey, can we say that we can introduce a charge of, let's say, $2 US, and exempting those who are unemployed and who live far from the facilities? Would that be a good policy option?
Thank you, highly esteemed opponent, for the question. So basically, in terms of introducing a charge, at this particular point, I think it will be a futile exercise, given they actually want to implement the national health insurance, where there's no fee for service even at hospital level. But at the same time, I'm sure if you look at some of the facilities, they have a component of donations, and if somebody wants to donate, maybe some of the patients might actually want to donate. Then on the aspect of the issue of ability to pay, we looked at that before we implemented the study, and the fact that it was a no-fee paying hospital, and we kind of assumed a lot of them might be unemployed. That's why they go to that particular facility instead of actually going to a GP. So going that route might not exactly have given us really much in terms of whether they're, in terms of their ability to pay. So that's why we actually took the position of looking at their willingness to pay and not necessarily the ability to pay. But I think that's something we could consider in the future. Thank you for the question.
Yeah, thank you. I would think that estimates like willingness to pay cannot be bluntly transferred to patient charges, and we should look at them more in terms of values than the prices that we should charge. But you also write in the last part of the that chapter that still we have to improve services in order to stimulate a higher willingness to pay. This was also one of the last conclusions in your presentation. So, but could you please tell me, how do you see how willingness to pay results can be used for improving services? What are the policy implications? What improvements should be made based on the willingness to pay results?
Thank you, highly esteemed opponent. So basically looking at those factors that they're actually willing to pay for, largely where they're willing to contribute money if those areas are actually improved, could become one of those policy areas that they can actually put more effort on and start with those in terms of priority setting. Thank you.
Clarifying and thank you for your answer. So I give the word back to the prorector.
Thank you. The opposition will now be continued by Professor Wim Groot, and he has a share in health economics here at the University of Maastricht.
Thank you, Mr. Prorector. The candidate, let me start by expressing my appreciation for your dissertation. I've read it with great interest, and I think your dissertation increases our knowledge and insight on public health economics, more specifically in South Africa. And that I think fills a gap in our knowledge, because most of studies on preferences are for medical services or treatment, and I think there's a really need for more insight into how people value and what they prefer in public health services. I wanted to engage in a discussion with you about the results in Chapter 5. In Chapter 5, you identify the preferences for HIV testing. And when I look at the results on page 106 and 107, then in Table 3 on page 106, you write that the relative importance of confidentiality is 65%, and that is by far the most important attribute in the discrete choice experiment. However, when I look at the next table, Table 4, there it says that where you do the analysis separately for respondents aged 18 to 34 and 34 and older, there you find that for the younger group, the relative importance is 62%, and for the older group, it's 48%. Now, I would expect that if you do your analysis separately for different subgroups, that the relative importance would be somewhere around the relative importance for the entire sample, or vice versa, that the relative importance for the entire sample is sort of a weighted average of the relative importance for the subgroups. This is not what you report here in these tables, where actually for the entire sample it's higher than for the subgroups. Could you explain to me why this is the case?
Thank you, highly esteemed opponent. Basically, I think it's in terms of the groups that we had, there's a big possibility. If I just look at the context of South Africa in itself, the fact that the older groups are kind of used to the health system flow. They're kind of used to the infrastructure flow. They know sometimes you're not necessarily going to get the amount of confidentiality that you need. And I would like to think that in terms of the younger group, as growing up and expecting better in the services and better in the infrastructure flows of where you actually have that much confidentiality, and you might actually have a higher relative importance within that subgroup as compared to the older group. But I would like to think mathematically that given the sample that we had, we ended up having these results.
Okay. Yeah. I'm a bit confused by your answer. I can understand that younger groups attach more value to confidentiality. I mean, they are in their, especially when it comes to HIV testing, they don't want their, most specifically their prospective partners, not to know that they have been tested for HIV, let alone, of course, if they tested positively for that. So I can understand that the relative importance that younger people attach to it, to confidentiality, is higher than for older groups. But that doesn't explain why for the entire sample it's even higher than that. Let me draw you attention to another finding in this table. If you look at distance, For the entire sample, the relative importance is 10%. But if you look at the subgroup analysis, it's 18% for the 18 to 34 years old and 17% for the 34-year-olds and older. So apparently for the entire sample, the relative importance is much less than for the subgroups.
I would like to think on the overall, when all the statistics are put together, that might have affected in terms of also the different contexts. If you look at the different age groups, and it could have been not necessarily the same when it comes to the overall groups in itself. But I think that's an interesting thing that I would also definitely look at as well.
Yeah. If I look at the number of observations, that seems to be the same in both tables. So it doesn't suggest that you have dropped observations. I was also puzzled by this finding, I must say, and I don't claim to have the answer to that. But could it possibly be that there is a correlation between distance and confidentiality? And that may have affected the results here.
Thank you, highly esteemed opponent. That's a big possibility in the fact that in terms of distance and in terms of other groups preferring to test at home, and in terms of other groups actually preferring a less distance to the facilities. And if you're testing at home, you probably have more there's a confidentiality aspect attached to it than actually going to a facility where you might know who might see you walking into the facility and who might actually tell the next person that you have been there. So that possibility is there, but I think you have raised a very important aspect of the study, and it's something that I would want to definitely go back and look at in the future.
Yeah. I think that's because it's important findings. Yeah, indeed. I think confidentiality is better assured if you go to a clinic that is further away. So probably these two attributes are correlated with each other, and that violates one of the assumptions, of course, with the discrete choice experiment, namely that these attributes are independent of each other. And I think at least my explanation for this is that it has to do with the fact that they are not independent, and that you Okay, that is what I wanted to discuss with you. I give the word back to the pro-rector.
Thank you. The additional opponent is Professor Hamers, and he is a professor of care of older people here at the University of Maastricht.
Thank you, Mr. Pro-Rector. Dear candidate, I've read your thesis with interest, and I think that you have adequately conducted and clearly described the different studies conducted. And I would like to compliment you and the supervisory team with the work and the publications. My first question would be more general regarding the methodology used. In most of the studies you have conducted, you give participants choices, ranging from the willingness to pay, which has been a topic in the earlier questions, to the different testing preferences in the HIV studies. And you ask which one they would prefer. And we know, however, that often there is a difference between what people say they would do or would prefer and what they really do. So we see, for instance, in a lot of studies we have done, when we compare questions about behavior, so we're asking people questions about their behavior and compare that to the real behavior using observations, that there's really a deviation between the two methodologies. So I was wondering, how will this have affected the results of your studies and probably the validity of the conclusions or results in your studies regarding, for instance, the willingness to pay? Could you please reflect on that?
Thank you, highly esteemed opponent. As you rightly say, in some instances, there's a difference between preferences and what somebody actually goes ahead and does in reality. So what we also actually did, I think it's one of the chapters I mentioned, that what we also actually did was just to look at the patient survey results and to look at areas that are being proposed for the national health insurance in terms of areas of improvement, and in terms of the patient satisfaction surveys that are conducted annually. Some of those factors were actually in there. So we would love to think that our results kind of showed a similar pattern to what they have had in those in the particular surveys as well. But we offered a different way of actually looking for the relative importance in terms of conducting the study. And in terms of the willingness to pay, as you mentioned, that do you think this is the way that people would actually, in reality, do that if they're offered that opportunity to do that? If I look at the sample of the people from the facilities that we actually were actually in the cohort, I would like to believe that because the amount came out quite low, it is something that they probably would be willing to actually pay. But if I would have been more shocked if there was a higher amount, and I'm looking at people, mostly students, unemployed people, and saying that we would pay this higher amount. So if that would have ever been an option at such a lower amount, I would think that in reality they would pay that. Thank you.
Okay, actually you say, well, the answers were in that way that you say, for instance, with regard to willingness to pay, the amounts were so low, well, actually this probably would be a reliable result, a valid result, people would do that. That's something you said. It seems a little bit like, well, it seems quite logical. Let me follow on that actually, because you mentioned also for doing the studies, an important argument is that the studies have not been conducted earlier in South Africa. And that was the reason why you said, well, okay, we will have to do that here. But keeping in mind your answer on the former question, when I was looking to the answers and the results, I thought, well, the findings are comparable to those in other countries where the studies have done before, actually. And most of the findings seemed very logical to me. For instance, when it came to the HIV studies, well, preferring the least invasive method, for instance, for doing the testing, well, quite logical, I think. Or when it came to, again, about HIV, the confidentially about of the test results and so on, quite logical. So I have a hypothesis, and my hypothesis is that a number of these attributes are general human ones. So no matter where you're living, do you agree with this hypothesis or not?
I think, thank you, highly esteemed opponent. I think, given your statement that they are general in some instances and in some contexts you actually get to find some of these results, I would think that's an accurate assertion. Things like confidentiality, you definitely, wherever you are, you want to have a situation where you're in a confidential space. Things like distance, it has, in all the other aspects, it has informed a lot of policies in different countries. People need to have healthcare services to be able to access healthcare near them. So I think they actually, despite the fact that this was a little bit off in the context of South Africa, it can actually be the same results for some of the countries.
Okay, then we have agreement. And I was wondering, what does it mean for future studies then? So what would you recommend when it's not in South Africa, but a different country, in wherever in the world? Should we proceed with this type of studies, or would you say, no, we should do different things because we know the results already?
Thank you, highly esteemed opponent. I think one of my recommendations was actually to look at the variations within those factors. When we speak of confidentiality, for example, and looking at the different levels that we have actually given, what is it that is within, beneath that attribute? What is it that is within the different levels? Can we tear apart the different levels and actually understand what's lying under there? Why would those patients go deep into particular in that level as compared to another?
Okay, and what type of methodology would you use in that type of studies?
Probably a qualitative research where we could actually also have different surveys within the facilities, depending on the participants that we have. Thank you.
Okay, thank you for your answer, and I give the word back to the prorector.
Thank you. And the additional opponent is from the UK, Dr. Kai Long Cheung, and he is working at the Brunel University in the United Kingdom.
Thank you,
The floor is
Professor.
yours.
Dear candidate, congratulations for this thesis. It's a very nicely designed book. I believe that your thesis is an important body of academic work contributing to the patient voice regarding the choice of public health facilities and also patient preferences for HIV testing in Africa. I have a question in regards to your nominal group technique. So in order to investigate the patient's preferences in facilities in Western Cape, you conducted the discrete choice experiment, and in order to understand what the important attributes are to feed into this discrete choice experiment, you conducted the nominal group technique. So I'm wondering what your academic rationale is to publish the latter as a separate paper, because typically in discrete choice experiments, I see the nominal group exercise being integrated into this in the same paper. And maybe one of the rationales that you also mentioned is that the nominal group technique, you showed that it is feasible and valuable for selecting attributes for discrete choice experiments. But I'm wondering, the nominal group technique has been widely used already in various settings and purposes. Why will it not be feasible and valuable to inform the discrete choice experiments? So in short, what is the academic relevance of Chapter 2 just to justify a standalone paper rather than integrating it?
Thank you, esteemed opponent. So basically what we did was to look at the context in which we are conducting the study. We could have used other methodologies like the Delphi technique. We could have just gone straight into doing a questionnaire, which is a qualitative, where they could just give us the answers. But we looked at the context of where we're operating. And where we were operating, it was a situation where you have patients that come in and patients that do not want to leave their queue. And being able to get one patient at a time could be, someone would say, no, I'm not leaving my queue here. So it made sense for us to actually have them in a group study, and it made sense for us to go through that technique as well. And rightly, as you said, it has been published in other discrete choice experiments, but we have not seen it being used in the context of choice of facility, and most probably in a public setting. So in that sense, we decided to publish that as a separate paper, which actually gives information of the nominal group technique within a public setting, and given the context that we have. Thank you.
Okay, thank you. Yes, I'm also actually wondering why not the Delphi method. So you mentioned that there are advantages towards the nominal group technique, that it might be more efficient to elicit responses, consensus, I mean, and also that it has a higher response rate, right? But yeah, with the Delphi technique, you could be easily extending your participants beyond those 4 settings, and also you would have anonymity and you might have a bigger sample, enhancing the generalizability, potentially reducing selection bias and response bias. So yeah, why did you not include the Delphi technique and chose for the nominal group technique instead?
Thank you, esteemed opponent. So I think it also comes back to the context as well, where if you look at the Delphi technique, you literally have to have the group, you do the discussions, you share the results with the group, and then they revise their answers depending on the results that have come through, and you do a couple of rounds in terms of actually the results that you get from the group that you have. And like I said, it depended with the context, and the context that we have were patients who have been waiting in the queue since 5 a.m. to be able to get into the facility. So the moment you start taking an hour or more of their time, then they probably would decide, I'm not going to participate, I need to go back into the queue so I'm able to see the nurse or the doctor on time. So I think that was just one of the reasoning. But if we had a different context in terms of the waiting times of the patients, how long they've been there, and if they're not afraid to lose their place in the queue, then we probably would have actually used that technique as well. Thank you.
Okay, thank you. I have another question related to your subgroup analysis in discrete choice experiments, chapter 5. You looked at the preferences for HIV testing among the South African population. And in South Africa, there's a high prevalence of HIV, testing rate is insufficient, and your results relate to the overall population with the only subgroup analysis conducted on age. And as you also referenced in your discussion section, the male population are much less likely to test for HIV than the female population, with 83% of your sample being female. I'm wondering what you think about potential selection bias regarding your findings. Yeah, that's the first part.
Thank you, esteemed opponent. It's a possibility that you would have a bias if you have a bigger sample of being the females. But when we actually look at the population within the two groups that we were looking at as well, in the Potosik and in the Goodwood area, you actually have a high number of females as compared to males. So it kind of would make sense for us. We're comfortable with the fact that the population itself is higher in females, and you then get a sample that is also higher in females. But there is also a possibility that there's a difference in the way females access healthcare as in compared to males as well, which has been widely written about within the literature. So I think that would be my response. Thank you.
Okay. Yeah, regards to another subgroup that I might be interested in is MSM, men who have sex with men. They are disproportionately impacted by HIV in South Africa, and with a rate nearly 5 times higher than the non-MSM counterparts. So yeah, I'm wondering whether they might have very different needs. So will that be captured within the overall group, I'm wondering? And will it not make more sense to conduct more subgroup analysis? Because you also mentioned in your presentation that it's important to tailor the interventions and the programs to the patients, right? So if you tailor or even target, then you need to understand the potential differences in their needs. So needs in important subgroup analysis from MSM versus non-MSM, but also in the sexes. So can you elaborate a little bit more on that, and what would your recommendations be in terms of intervention design, for example?
Thank you, esteemed opponent. Rightly so, as you said, we need to tailor our whatever we do, we need to tailor it according to the groups. And in this case, I think the study manages to show exactly that, in the sense that you have a smaller group of men coming in and you have a bigger number of females coming in. Already I would ask, if I'm a policymaker, what does this mean? Is there something that we're not doing in terms of providing that service to males? And what is it that we can tailor to bring in more males for testing? So I think the study manages actually to show that, given the numbers that we saw who were coming in for testing, that were more female than male. Thank you.
Okay. And in terms of your recommendations, so you had, based on your discrete choice experiments, you can see what the preferences are for the overall group, but it's difficult to estimate for the subgroups, right? And you acknowledge that. But what would your recommendations be specifically if you would have to design an intervention, let's say health communication to patients, to enhance their knowledge about that quality is actually the same between doctors and nurses, for instance?
I think one of the biggest issues that we have in South Africa is the issue of looking at a doctor and looking at a nurse. And probably this is also in the worldwide other countries, that people tend to think a doctor is more qualified than a nurse. So they tend to want to see a doctor. And I think this is one of the issues that really needs a lot of education in that. Pamphlets could help as people are sitting, in terms of when they're waiting, because if you look at the patient flow and the way the service is structured, you see a clinical nurse before you see a doctor. And the clinical nurse decides whether you need to see a doctor, or you can be de-referred and come back another day. And already you have now people being angry, why didn't I see a doctor? So I think it really needs to be tailor-made into showing the differences between the different cadre. The clinical nurse have a pamphlet that explains what does a clinical nurse do, which is not so much different from what you would get if a doctor does. How do we do that? Do we do it in pamphlets? Do we do it as adverts? Do we do it as social media adverts? That's another option that could actually happen. And I always say, catch them young. And for me, what's actually important when it comes to health promotion is to do it in schools, because when they're young, they get to understand more. The problem is you don't have that happening in the education system. So you get to form your own thoughts about the qualifications of a doctor and a nurse. If that was already taught at a young age within the school system, I think that would have been a better option. Thank you, esteemed.
Thank you. Thank you for your answers. I give the floor back to the Prorector.
Okay, the opposition will now be continued by Dr. Elena Petelos, and she has a position at the University of Crete in Greece, and she's an expert in evidence-based medicine, evidence-informed policy in public health. The floor is yours.
Thank you, Mr. Prorector. First of all, I applaud you for your passion, because it's difficult to work in the public sector and conduct research. And you can tell by reading your book that you're not only familiar with universal health coverage, but you really want to look at ways of implementing and making access happen. So congratulations for that, and of course to your supervising team. I think all of your chapters present concrete challenges in conducting research and looking into it, and I think you've done a wonderful job on that. I'd like to touch upon two particular chapters, starting with my first question for chapter 4, but looking at a little bit different. Looking at your data, I saw you had captured the reason to attend, you had looked at chronic versus acute complaints, but nevertheless, you were not capturing frequency of utilizing the services, and largely for this particular chapter, for this selection of participants, but overall, our willingness to pay and is linked to likelihood to consume. So having looked a little bit at your national survey for South African adults and youth, I've seen, for example, that for HIV, over 31% are also hypertensive patients, so which could explain, of course, some of the attributes and some of the responses in wanting to receive other care levels or even referrals and so on. So I would very much like you to elaborate a little bit on that, on whether you looked at that or whether you'll be interested in that, and whether you think this affects in any way the interpretation of your results and how they inform policy recommendations.
Thank you, esteemed opponent. What we managed to do was to aid the facility visit in terms of frequency of the patients that were coming in. So we had if you look at the variables, we had a first-time visit. Is it a first-time visit? Have you been coming between 0 to 12 months, which means you've been frequently coming, and is your visit have you been coming for more than 12 months visiting this facility? And we also added the reason for the visit. Is it because you have a chronic disease that you continue coming, and that's why you're here, or you're actually just coming in for one condition? So I think in that aspect, we try to look at that as an indication of if you had been coming more times and you exactly know the service that you're being provided, then you should be able to value that. And if it's your first time visit, how do you feel about this visit and what you're seeing at this particular point in time? So I think, as you rightly said, it would be important to have a wider research or a wider survey in terms of the frequencies, in terms of utilization, because utilization is one of the big components anyway in policy and policy making. A lot of the indicators around healthcare look at the utilization factors. I think it will be interesting to have another research where you actually look at the utilization, and you can probably throw in the differences in terms of willingness to pay and other things. Thank you, esteemed opponent.
Thank you. So glad to hear you looked at some of it and I saw some of the capture. Did you consider in your analysis, for example, Latin attributes, the difference between people attending for somebody else or bringing with them a child for maternal care services or caring for an elderly?
Unfortunately, we did not consider that, but I think it's one of the first chapters for the main study where we actually do show some information that some of the people came with guardians. So it was, yes, so it was the guardians who actually helped, because we had quite a number of over 65s who had their guardians in there.
You mentioned the word guardians versus carers, but you clarified, thanks. And the second question, This is my particular field of expertise. I found it quite fascinating that you were attempting to link testing, so diagnostic testing, which poses certain challenges in when wanting to measure willingness to pay or attributes or any other aspect. Now, in your relevant chapter looking at that, you had approximately 200 people. It's not clear whether they were patients or people, whether they were there for themselves or for someone else. And considering your national guidelines, it's also unclear whether they were coming there to test also for TB, for other NCDs. You have currently in place in South Africa guidelines for integrated management. So I do not know to what extent they've been exposed to systematic messages for screening or for testing for HIV. So I want you to, or I'm hoping that you will elaborate a little bit of that. And also, having noticed that you mentioned you referring to 2017 research on men preferring in the US having a test of venipuncture or finger pricking versus oral test. This pertained to the different time. Diagnostic tests largely changed. So my question would be, to what extent do you think this carries relevance 3-4 years down the line with new diagnostic at home testing for South Africa and in general? And to what extent do you think this can be utilized to actually deploy or design a service? Overall, also, I found this interesting contextualization because I didn't see you elaborate. I was hoping to find this in your discussion. I didn't quite see you elaborate the link between diagnostic testing, seeking services, and indeed contributions towards a national health insurance, which I think ultimately this was a very strong aim in your work. Thank you.
Thank you, esteemed opponent. To answer the first question in terms of HIV, so basically the way the service is structured is when you come in, and you want to go and have an HIV test, you have your separate line for HIV testing. And if you are going to go for other services, you have a separate line. So this actually also informed us to say, oh, but there is a service that is actually particular. So we can actually look at that cohort, which is given their own line to go in for testing in terms of the differences in whether they're coming in for a TB test or they're coming in for other things. We knew particularly they're going for HIV testing. So that's to answer the first question. Then in terms of the testing for men preferring venipuncture versus oral, as you rightly said, different times, different diagnostics, and as we move with the times, things tend to change. There's new research coming in, so it would be nice with time as well to actually look at that. But then if you also look at settings like most countries in Africa, you actually also see that, for example, home testing, it's fairly new if you look at when it was introduced in 2017. So, and there hasn't really been a lot of advertising on it. So in people's heads, they still, I need to go to a facility to go get my finger pricked or to get my arm pricked for the test. So I think, as you said, with future times, with more informing the public, then probably that would change. Then in terms of diagnostic seeking and NHI, the link between those two, I think we concentrated mostly on the national strategic testing strategy when we looked at the study. It was basically more focused on that, and I think it's because even if there is the national health insurance, that HIV component still forms part of the healthcare provision. It's a key healthcare provision. It has its own standalone strategy, so it will not be lost in translation. It is part of the national health insurance, and it's part of a priority as on its budget in terms of the testing and the treatment. So I think it fits into that perfectly. Thank you, esteemed opponent.
Thank you. I hope this last aspect you also capture in a policy mapping paper. Thank you.
Definitely.
Okay, the opposition will be ended by Dr. Inge van der Putten, and her expertise is health economics.
Dear candidate, also from my side, congratulations with your dissertation. I will keep it a little bit short because you had already a long defense happening. So my first question was, what I wanted to discuss was about the differentiation between the nurse and the physician. However, you already made a very lovely statement on that before, so I will just skip that. But I have another question also on the methodological issues on your discrete choice experiment in chapter 3. So I don't think we have discussed that yet extensively. So I was looking at that discrete choice experiment, and did you find any findings surprising to you when you were looking at your study? So when you published it, are there any things that stuck out to you?
Thank you, highly esteemed opponent. I think it's in terms of the context and in terms of not so much of the surprising. It's one of those things in research where you go in, you don't know what you're going to find, and the nice to have is to find something totally different. But in some instances, you don't find something very different. And I think that could be one of the situations. But at the same time, the question you ask yourself is, have I contributed anything to this particular setting that I am conducting this discussion? And as we rightfully said, the discrete choice experiment had not been done in South Africa in terms of public facilities. And we think and would like to think we have contributed something. The nominal group techniques, it had not been done. We would like to think we have contributed something in that setting. And we would like to think that some of the information that came through, for example, one of the big issues was availability of medication. Obviously, that is going to affect health outcomes. Obviously, you can find that in any setting, because the reason one goes to a facility or a hospital is to be able to get treated. But at the same time, when we look deeper in our context, it actually brings out the fact that there's some cases where you don't get that medication, which could not be the case maybe in Europe, but in our case. So it's something that in terms of policy, they need to zoom on what is happening with the stockouts that patients actually feel, I'm not going to get all the medication if I go to that facility. So I think in terms of the context, we were okay.
Okay, yeah, I was also finding some surprising outcomes actually. So when you're looking at your table 4, you have an overview of the differentiations between male and female. And if you're looking at that table, you indicate that actually males have a preference on going to 5 to 10 kilometers to go and find facilities there, while females want to have it very close. And then also they like 4 hours better waiting time than 2 hours. So I was surprised about those findings. Can you give any clarifications on, or any notions that you have on these findings, on why you did find them?
Thank you, esteemed opponent. I think in terms of females actually wanting a place that is nearer, one of the explanations we give is it's probably because of the responsibility that a lot of females hold. They want to get home as quick as possible, and which that responsibility is not.
You can continue your answer shortly.
Okay. So probably because of the responsibilities females carry more than males. Thank you.
Plaxcedes Chiwire, the time appointed for the defense of your thesis has passed now. The degree committee will now withdraw to discuss the quality of your thesis and your defense. And I request you and your company await the results of our deliberations and our return here in this room.
Thank you, highly esteemed opponent.
Okay.
The PhD defense has now ended. The degree committee will debate the candidate's performance behind closed doors. This process usually takes about 10 minutes. In the meantime, let's take a closer look at Maastricht University's renowned teaching method, problem-based learning. Once the prorector reconvenes the session, we'll tune in and continue the live stream.
problem-based learning, or PBL. What does that mean exactly? 3 of my fellow students and I will show you around. Every week, we analyze a different case or issue together. We discuss the case and everyone can contribute different perspectives to the group discussion. If we get stuck, our tutor helps us out and suggests what we could do next. I prefer going to the library to prepare. Here, I can focus and I have quick access to books or journals that help me understand the case. Today, I can also train my stitching skills in the Skills Lab, where you can immediately put into practice what you've learned. After a day like this, I like going to the gym to clear my head and get ready for the next day.
At UM, you meet people from all around the world. Hello guys. Some of them are doing their exchange semester here, and they often say that PBL helps them learn and retain things very easily. I can understand why. It's a very active way of learning because you have to bring your own perspective to real-life cases. You have a lot of freedom to manage your time, your studies, your hobbies, and your work. Of course, that also means a lot of responsibility. Right now, for example, I'm arranging my exchange semester in Madrid. How cool is that? In this group session, we're the managers who have to allocate the resources of a real company. This is how we put into practice what we learned this morning. Studying here means being proactive and learning to plan well. Prioritizing and performing well under stress are great skills that help you develop as a person. But now, it's time to grab a coffee at the Student Service Center.
Right now, we're at the Brightlands Camelot campus. Here we can apply knowledge from lectures and tutorials in a practical setting. This helps us understand what we have learned and further develop our lab skills. Today, we're determining the amounts of cholesterol in various products. What I really like is the project periods at the end of each semester, where we complete a full research project. That includes planning, collecting data, analyzing, and presenting the findings. That way we learn how research works and we're able to see what it's like to be a real scientist. After practicals, I have to write a lab report that also helps me process everything I have learned today. UM has a lot of learning spaces where you can work on your own or with other students. This evening, I'm meeting my friends for a movie night organized by the MSP Study Association.
If you study law, you have to read quite a lot. Not all information is relevant, so you learn how to easily find the information you need to solve your case. In the afternoon, I have to give a presentation, so I like to practice it with a fellow student. Later today, a lawyer is giving a lecture. This will help us better understand the case we're working on. Speaking in front of a group is quite exciting the first time round, but you get to used to it quickly. And having to present helps you also to adopt knowledge better. What I like the most is that we sometimes get to enter a plea in front of a real judge. These moot courts are really exciting. Now it's time for drinks with friends. Studying is important, but so is relaxing once in a while.
Plaxcedes Chiwire. The degree committee has here present has assessed the quality of your thesis and your defense. In view of its positive verdict and taking into account your previous qualifications, the degree committee has decided to grant you the degree of doctor. Professor Evers is authorized to confer upon you this academic distinction in accordance with Dutch University custom, and I invite your supervisor to take now the floor.
Do you promise to work in accordance with the principles of scientific integrity at all times, to be careful and honest, transparent, independent, and responsible?
I promise.
By the authority vested in us by law, in conformity with the decision by the committee here present, I hereby confer upon you, Plaxcedes Chiwire, the degree of doctor and grant you all rights attracted to custom and law. As evidenced by this, I'm going to present to you the degree certificate signed by the rector, the secretary, and other members of the committee, and affixed with the official seal of the university.
Dear Plaxcedes, dear Dr. Plaxcedes Chiwire, you have done it. The PhD project has come to an end. It is my honor to be the first, on behalf of your supervising team, Sylvia and Hassan, to congratulate you and your family on this big accomplishment. In 2016, you sent an email to me and Annerike van der Boom. I was able to refine your email. In this email, you introduce yourself as a 34-year-old lady looking to pursue a PhD in health economics in the coming year. And you wrote year, not years, in plural. And was hoping we could assist you with more information. And then we started the collaboration on the first project. And then 1 year after you become officially a PhD student. And at that time, you probably never expected to be done 6 years later in 2022. But it took certainly a few years to get a PhD. And an external PhD is very, very challenging. You was working full-time. You have children that attract a lot of attention. And publishing, doing research takes a lot of time. But you never give up. You published 4 papers as part of your dissertation. And it became always more and more easy to have your article published. I remember we were not really lucky with the first one and for review rounds. But your enthusiasm and your determination were without a false note. We are proud of your work, proud of you, and we wish you all the best in your professional and private life. We are also very pleased to see you for the first time, face-to-face at Maastricht, a day that will certainly remain important in your life. Not only for the very long trip from South Africa to Maastricht, but also for getting your well-deserved PhD degree, and also for seeing your promotion team face-to-face at Maastricht. Sylvia and I will miss the wonderful beaches from South Africa on your Zoom screen, but we hope to have other opportunities in the future to be in touch and to meet you. Sylvia and I also would like to thank Hassan, that accepted to be co-promoter and that provided relevant support and supervision through this process. And as you know, Hassan is in South Africa, but is also participating online to this defense, and he also would like to say you a few words. Thus I give the word to Hassan. Congratulations.
Thank you.
Thanks so much, Plaxcedes, and thank you, Mikhail. Thank you for the opportunity to speak on this momentous occasion. Firstly, we thank the primary supervisors Mikhail and Sylvia for allowing me to be part of the supervisory team. They have been of tremendous support to Plaxcedes throughout the PhD program. Plaxcedes is an amazing woman and fully deserves this PhD. Besides her duties as a parent and her responsibilities as a full-time employee of the Western Cape Department of Health, she is also a woman of colour. But despite all these challenges, she has worked with resolve and commitment to complete this PhD work. Her knowledge and experience will enable her to be a highly productive member of the Provincial Government Service, and we need to thank Maastricht University for giving her this opportunity. Congratulations, Plaxcedes. A bright future awaits you. I'm sorry that I'm not able to be there with you, but I will give you a big hug when you are back in Cape Town. Thank you.
Dear Dr. Plaxcedes Chiwire, as pro-rector of this university, I would like to congratulate you on behalf of the university with this very important moment in your life. You should be proud of it. I congratulate you with the degree you have acquired, but also with the defense and with your presentation this morning. You did a very good job. I also include in my congratulations the team, and I thank all the opponents for their presence here and for putting very interesting questions, some of which were difficult, I believe. Do I speak on behalf of you? Okay, anyway, we end now this session, but before we leave this room, we are going to make a photograph, and we do so that also our co-promoter from South Africa is on the screen. So, and then there is a possibility for reception, and that is somewhere in the city, but I lost the name. Basilica. It's on the Vrijthof. Okay? Thank you. Then I now close this session.
Thank you, Rector.